Thank you, Chairpersons. At the outset, I'd like to thank Dr. Bansi Sabu sir and the team, particularly Dr. Rutul, for the opportunity. I'm going to talk on improving postprandial glycemic control. After talking about basal insulin, second generation basal insulin, and GLP insulin, GLP analogs combination with the basal insulin, now it's a time to have a discussion on ultra-acting, ultra-rapid insulin, particularly ultra-rapid Lispro. How to use this molecule to have a better postprandial glycemic control. This session is sponsored by Cipla also. So Dr. Bansi has said, we have to have one history of diabetes. This is the first diabetes clinic has been started in 1914 at Vienna by a German physician called von Norden. Even before the discovery of insulin, he have a structured diabetes clinic in such a way that he educated our patients about diet counseling, and all these things he has started. Later, 1916, the US, the first diabetes clinic has been started by Elliot B. Joslin, who has even this is also happened before the discovery of insulin. He had a good number of registry, so diabetic individual patients registers has been well maintained. So once insulin has been discovered, he can able to present the data what happened before insulin and after the insulin. And our in India, our father of diabetology, Professor M. Viswanathan, has started first diabetes clinic in 1948. Government Stanley Medical College, where I worked more than 6 years as a professor there. So his passion to start diabetes clinic was he saw many patients dying of diabetes, so he wanted to start a diabetic clinic. At that time, he was allowed to do just 2 GTT per week. That was a scenario while starting the diabetes clinic. So now this diabetes clinic has been upgraded to Institute of Diabetology, which has been center of excellence. So many studies are happening at Government Stanley Medical Colleges. This is thanks to the pioneers who started the diabetes clinic in India. This is about the history. My content of flow will be why this postprandial plasma glucose is most important, what are the risk factors, where is the gap in current management, and where this ultra rapid Lispro Urli have a role in managing this postprandial plasma glucose. So postprandial plasma glucose, we all know that because of loss of first phase insulin secretion, this postprandial rise happens, this first phase insulin secretion, loss of first phase insulin secretion happens even before the decline in beta cell mass. So that is why we come across some patients, those who are having postprandial levels are lower than the fasting, even in pre-diabetes. We know the IGT. There is one stage before the IGT, we come across a normal master checkup, postprandial levels will be lower than the fasting. It means that patient is started losing the first phase insulin secretion, the second phase insulin secretion is sustained and more prolonged. So this group of people has to be picked up. So having said that, this first phase insulin secretion will be the early defect in type 2 diabetes mellitus. So that is why the postprandial exertion happening in most of our type 2 diabetic patients. We all know that postprandial glucose has been independent risk factor for many of our diabetic complications, not only microvascular, particularly macrovascular, cardiovascular events, and all-cause mortality and cognitive dysfunction. This is the most important point. So many of patients says that, sir, after eating my breakfast, I feel sleepy, I feel dizzy, all these things because of rapid rise in blood sugar rather than hypoglycemia. So cognitive dysfunction is one of the commonest factor for our postprandial hyperglycemia. So postprandial control is most important for our type 2 diabetic patients. Postprandial response, insulin response happen because of rapid surge in the glucose in the beta cells, and also the by incretin pathways. This first phase insulin, which is happen within 0 to 10 minutes. This is the most important parameter in a normal healthy adults. So the first phase insulin response is why it is important. We all know that there is a hepatic glucose output happening overnight, which will take care of, we don't go for fasting in overnight, even though we are not eating. So this hepatic glucose output maintains some good amount of sugar levels over the period, 24 hours. So once started eating, the first phase insulin response, the sudden surge in first phase insulin will abruptly stop the hepatic glucose output. We all know that there is something called paracrine effect. The first phase insulin response is abruptly stop the glucagon secretion from the alpha cells. So this abrupt rise in the first phase insulin will activate the insulin receptors. Therefore, the more GLUT4 receptors come into the surface. So it makes ready for the second phase insulin. So the first phase insulin is the most important parameter. If you want to address the postprandial insulin, this has to be there. This is the first insulin response to be lost in type 2 diabetes mellitus. That is why even in IGT, the postprandial levels goes up even before the fasting levels rises. What is the pattern of postprandial levels? In normal population, if you see healthy adult population, the 1 hour this is a peak happening in 1 hour. The 1 hour postprandial will be around 70 to 100. It rarely touches 140. But in type 2 diabetes population, this is the ratio. In type 2 diabetic population, almost 80% of time, 80% of peak in plasma glucose happening within 90 minutes, within 1.5 hours. So 30 minutes, almost 21% happening, and in another 60 to 90 minutes, 55% of postprandial peak is happening. So that is why the IDF also suggests that. So 1 hour postprandial is also most important parameter to be considered whenever we are having a treatment strategy or treatment goals for type 2 diabetes mellitus. So there is a mealtime gap. We all know that whatever the insulin we want to inject, we want to replace normal physiological insulin response. The normal physiological response, we know that there is something called prandial dose and the basal dose. We place the insulin according to the pharmacokinetics and pharmacodynamics. The insulin mean interval has been adjusted such a way that if you're going with normal conventional insulin, we take 30 minutes before the onset of insulin. We know that onset of action for normal conventional insulin, human insulin will be 30 minutes. So we inject the insulin 30 minutes before the meal. If you go with short-acting analogs, we 5 to 10 minutes. Usually it is recommended to have a short-acting analogs 15 to 20 minutes before the meal. As a physicians, we do feel that almost 91% pre-meal dosing was extra burden for our patients, and pre-meal dosing is negatively affected emotional well-being. It is more difficult. Many of time our patients used to miss because of they used to forget, and many patients what they do is most of our patients take insulin just before the meal. Almost 44%, more than 1/3 of patients, almost half of our patients take insulin just before the meal. So the insulin which will have just before the meal, which have a better postprandial control, which is replaces 1 hour postprandial, which is have a better control in 1 hour, which is have a somewhat mimicking normal physiological insulin, particularly the first phase insulin response, will be a very good insulin for type 2 diabetes control. So we want to have a better postprandial control, that too particularly 30 minutes to 90 minutes and extended up to 2 to 3 hours, so that we can have a better postprandial control without having pre-meal hypoglycemia. So there is evidence that rapid acting insulin obviously have a less risk of hypoglycemia, but something called ultra fast acting insulin, which will have a better mimic physiological insulin response, it also have a better postprandial control than the rapid acting analogs or conventional insulin. That is one among them is the ultra rapid Lispro, otherwise called URLI. So ultra rapid insulin analogs, this is nothing but it is a Lispro insulin. There is two component has been added into the Lispro. One is prostacyclin analog, which is treprostinil, which will have increases the local vasodilatation will be increases by treprostinil. Another component added will be citrate, which also increases local vascular permeability. The amount included here will be very, very less, even 1 in 1000th of therapeutic dose of prostranil or citrate. There is only 1 microgram of prostranil available in 100 ml of Urli, and another just 4.2 milligram of citrate is available in 100 milligram of Urli. Its dosage will be very low, it won't be get absorbed, so you don't worry about adverse effects of this molecule. This is what this Urli is. It increases vasodilatation. It also increases vascular permeability, so that the monomers getting absorbed very rapidly. The short-acting onset will be very quick. The onset peak duration will be short with ultra rapid Lispro compared to normal Lispro. So this is what the pharmacokinetics of ultra rapid Lispro. So after administration of Urli, the time to maximum insulin concentration happening within 57 minutes compared to Lispro, which happened almost 70 to 80 minutes. This ultra rapid insulin will have a very peak, almost mimicking normal physiological insulin response. So this is onset of action is 11 minutes faster than the Lispro, and only had 3-fold greater glucose lowering effect than the Lispro, and maximum glucose lowering effect will be occurred within 1 to 3 hours. This is what a period we want to have. We want our patient have a better postprandial control. We don't want our patient have a pre-meal hypoglycemia. This is what happening with ultra rapid Lispro compared to conventional Lispro. Compared to another other short-acting analogs, this ultra rapid Lispro will be 5.9 minutes faster than the Fiasp, 12.5 minutes faster than the regular Lispro, and 13.9 minutes faster than the Aspart insulin compared to other ultra rapid insulin. And the postprandial control also, the early postprandial profile will be better with ultra rapid Lispro compared with any other insulin, short-acting insulin like Lispro, Fiasp, or with Novarapid. So the phase 3 studies, we have two data here to present here. This is one Fronto 2 type 2 trial, which they have compared with ultra rapid insulin Lispro with the Lispro in basal bolus regimen in patients with type 2 diabetes mellitus. It is an 8-week running period. This study period is almost 12 weeks of intensive basal bolus titration and 14 weeks of maintenance period and 4 weeks of safety followed up. This is HbA1c similar control with Lispro. So ultra rapid Lispro will be non-inferior to Lispro for change of HbA1c. The change happening only here in the postprandial control. Particularly 30 minutes to 4 hour postprandial control will be better with ultra rapid Lispro compared to conventional Lispro, and the hypoglycemia incidence almost similar with this, and adverse effects also almost similar with Lispro. So this is about another study with type 1 diabetic, the same running period of 8 weeks of running period, 12 weeks titration and 14 weeks of maintenance therapy. Here also, if you see that just pre-meal ultra rapid Lispro have a, even though they have a same HbA1c reduction, the HbA1c postprandial exertion will be lower with ultra rapid Lispro compared to regular Lispro. So over a period of 6 weeks, the hypoglycemia incidence almost similar with this, and the adverse events also almost similar with all the group. So the key takeaway from the Fonto studies will be ultra rapid Lispro will be non-inferior to Lispro in terms of HbA1c control, but it significantly reduces postprandial exertion, particularly for 30 minutes to 4 hours, and it is no significant difference between hypoglycemia and significant adverse events between the groups. So therapy related satisfaction, which is the most important parameter whenever we consider insulin therapy. This is about ultra rapid insulin have a greater satisfaction in terms of glycemic control, in terms of quality of life, will be better with ultra rapid Lispro compared to any other insulin considered. To conclude my talk here, so ultra rapid Lispro will be 10 times faster onset of action, resulting in up to 3-fold greater insulin action. Duration of action was shorter by 44 minutes with ultra rapid Lispro. It closely matched with early physiological glycemic glucose control in healthy subjects. This is what we want whenever we are treating our type 2 diabetic patients. We want a normal physiological insulin response so that we can have a better fasting postprandial without having hypoglycemia. So it significantly better postprandial exertion, particularly action starts by 30 minutes to 4 hours. So it is offers good glycemic control without inducing risk of hypoglycemia. Thank you for your patient listening.
Thank you.